Darrell Gaskin. Darrell is a distinguished health economist, professor at Johns Hopkins University. But I will say, in addition to this, Darrell has improved education and research all around the area, having been at Georgetown at the University of Maryland. I don't think you've done any time here. So this counts. This counts. And your contribution to the intellectual skill knowledge of the area in general. So Darrell has done a wide variety of research. In addition to his research and his teaching, he's been actively involved in a number of professional and community affairs. He's currently on the board of directors for Academy Health, on various IOM committees. I will say that he did some time, I share this in common with, he was on the board for Maryland's Health Insurance Exchange, so was involved in some of those efforts. What Darrell will be talking about today, you see the topic, nonprofit hospitals' provision of charity care is commensurate with the value of their tax exemption. This, sort of gets at a question I've often wondered. Being as we are right in the shadow of George Washington University Hospital, as most of you know, most hospitals in the U.S. are nonprofit. For those of you who have not had the good fortune to have been a patient in a hospital and you see these whopping hospital bills, there's part of me that says, what do they do with all that money? There's an immense amount of money. Most of them are nonprofit, so what happens to it all? Darrell will provide some insights into what they do that relates to their nonprofit status, their charity care provision. Following him, Maureen Byrnes will be giving a talk or be a discussant. Maureen is a lead research scientist here in the Department of Health Policy. Has been working closely with Sarah Rosenbaum on a very similar related project for a while. And Maureen, again, has a stellar background, has involved doing work in foundations, on the Hill, has been someone who's sort of well-respected in the health policy community for a long time.
So, first, let me just acknowledge first my partners in this endeavor, Jerry Anderson and Bradley Herring and Hussein Zareh. They are instrumental in getting this work done, and then also Ted and Graham for their assistance in really financing this endeavor. This is an interesting piece of work because, in a real sense, as Leighton indicated, a lot of hospitals in the country are not-for-profit hospitals. They generate a lot of revenue, a lot of profits, and we wonder really what happens. What do they do with those profits? Especially since their status affords them to not pay taxes on the revenues that they gain. So this particular study has with it four aims that I want to get at. One is I want to sort of look at what they're reporting with regard to charity care to the two agencies that asked them to report this money, and then how it varies across not-for-profit hospitals in particular. Then I want to do a calculation in which we compute the value of their tax exemption, and then I want to compare that tax exemption or the value of the tax exemption to their provision of their charity care. So this is sort of like back to the future for me, because long ago, but even before I started working on a PhD in health economics, I found myself at the GAO and was an evaluator there and was assigned to a project to look at the not-for-profit hospitals, their tax-exempt status, and whether there was standards, whether there needed to be better standards around the exemption itself. And so I really found it quite ironic when Jerry and began talking about this project, and we talked about it with both Ted and Graham, and said, wow, this takes me back literally 25 years. And it's unfortunate that you see that the same question still is there. I think actually Mark might have been here, right? Mark Nadell, maybe. But anyway, these are the persons that worked on that wonderful report with me. And we basically concluded back then that better standards were needed, that the hospitals were not providing charity or other community benefits that were commensurate with the value of their tax exemption. Why do we care? Well, not-for-profit hospitals are exempt from taxes because they're organized as charitable organizations under the IRS tax codes. And so that in some sense they're not allowed to pay their net income as dividends or profits to shareholders or to owners. That money has to go back into the organization. And so the question then becomes, well, what is hospital charity? And that has evolved over time as the healthcare market has evolved over time, because maybe in the 1950s, 1940s, hospital charity was just operating the hospital itself because there wasn't a lot of payment, third-party payers covering everyone. But once you move into the area in where Medicare and Medicaid are passed, and now we have a way of paying for our seniors and both are poor, then we have to begin to really think about what it is that we mean by hospital charity. And so the IRS tried to provide some guidance. I think this is probably 1967, 68, on trying to at least create some sort of community benefit standard. However, it's still, as the hospital business has become much more lucrative over time, the community benefit standard is really quite mushy. The issue here becomes a great issue because we pay one in every $6 is in the economy is a healthcare dollar. And so that's a lot, that's a huge part of the economy. And then when you think about what Medicaid does to state budgets, it is also problematic because government is looking for resources. People are concerned about how much healthcare is costing them. And so when you have these entities that are sitting really in the heart of major metropolitan areas, they look very wealthy, look like they're well-to-do, sitting on prime real estate, and they're not paying real estate taxes, not paying state and local sales taxes or income taxes, not paying federal taxes, not really contributing to the coffers, community coffers themselves, and at the same time we still have problems in which people are uninsured, people are underinsured, and they need care. Then it becomes almost as though someone put a big old bullseye on the side of the building and said, you know, fire at me, please, because trying to justify why we have these organizations are tax exempt is problematic. And the other thing that is also creates a problem is that there are for-profit or investor-owned hospitals. And other than when I did this study at the GAO, one of the things that we discovered, you know, we went and visited not-for-profit hospitals, went and visited for-profit hospitals. When you went and visited the not-for-profit hospital, you walked and the place was beautiful. It was a gorgeous looking place. You walk in the boardroom had solid, you know, hard oak tables with pictures all around it and carpet, plush carpet. You go into the for-profit hospital, you had this stark workspace that you just sat down and you talked to people in. And so you got the sense that really what we were doing is putting all our money on the walls and on the floor and in the furniture, and not necessarily in the patient in these facilities. So what the IRS did, this is through their hospital compliant program. They defined what community benefit were for hospitals, and this happens in 2009, and they essentially says, well, hospitals should provide charity care. They also get unreimbursed costs for Medicaid and means-tested programs. They get these community health promotion and health education programs. They get any subsidized medical services, research, community activities, health professional education, and cash in kind contributions. So this is now what we call our community benefit. And so we looked at this and had some discussion around whether we thought that these things actually are things in which the community needs the hospital, the not-for-profit hospital, to do, and whether in fact we want to give them credit for doing it and measure it. So we focus primarily on charity care, thinking that charity care would probably be the most valuable thing that the hospital is providing. The other stuff, I remember when we were doing the 1990 report, our feeling was that this other stuff was stuff that, for the most part, investor-owned hospitals do, and we don't give them credit for when they treat Medicaid patients, and they just accept the Medicaid reimbursement. These community health programs and education programs, we said they were more like marketing tools that with maybe the exception of the research, but if the research is funded. So we're not, I mean, even though my office sits out right, I look at the dome right up, I can open up my blinds and look at the big dome at Hopkins. We're #1 hospital in Maryland, #3 in the country, not-for-profit institution. But even so, even though I sit and look at it every day, this is the thing that really we think is the value here. And there's some people who would argue with us. And so one of the things in doing these kinds of studies, and why we were willing or thought to do the study, is that when you measure hospital charity care, back there in 1990, we couldn't really measure it. There were really no data out there. The best data would have been the AHA annual survey of hospitals, which is self-reported data. It's not really audited data, and then it was proprietary data, so you had to have special permission to get it. And so the fallback position was always to look at uncompensated care as to charity care and to use this AHA database. And the reason for using uncompensated care was because hospitals couldn't or didn't consistently distinguish between what we would call a mission accomplished versus a financial failure. A financial failure is, I have a debt, someone owes me some money, and I failed to collect it. A mission accomplishment is that there's a person out there who needs health care and who can't afford to pay for it. I identify that person and I provide them health care. And so in their accounting, hospitals did not routinely distinguish between the two. And to some extent, they have no reason really to spend the money to distinguish between the two, in the sense that usually the way in which the charity care would occur is it wasn't necessarily proactive, it was more reactive. The person comes in, we give them the care, we define that they can't pay for the care, and then what we do is we then decide to write off the bill. We don't pursue them and send it to collection. However, if you really care about charity and the amount of charity that the hospital provides, you want to be able to distinguish between mission accomplishments and the financial failure. Through the hospital compliant program that was initiated in 2009, hospitals began to report standard reporting on Form 990 on Schedule H. And then in the same time period, what's happening on CMS side, CMS is revamping its Medicare DISH program as well as its Medicare electronic health record program, and they're going to use charity care reported on the cost report to help them figure out who's eligible. So now you have two incentives here for hospitals actually to report what they're doing, whereas that didn't necessarily exist. People tend to be afraid of the IRS. The IRS come and if they ever came and audited you, they could probably shut you down. They could take money from you, and then you'd have to fight them to get it back, and so forth like that. And then CMS, obviously you don't want to be on the bad side of Medicare and Medicaid if you're a hospital. So the other thing that happens during this time is the ACA. And in the ACA established some new requirements for not-for-profit hospitals to maintain their tax exemption, 3 of them which pertain directly to this issue of charity care. And the law prescribes that hospitals should provide some financial assistance, have a financial assistance policy. They should, it clarifies how the hospital should provide that charity. It prescribes that the policy should identify who's eligible, have an application process, and also state the consequences of non-payment. And then it says you should publicize the policy, and then you also cannot say charge the charity patients your list charges. You can't value it at their list charges because nobody pays list charges in the hospital. And then it also says how you should bill. Make some restrictions on billing, that you have to at least make sure that the person is not eligible for your charity before you send them off to the debt collector. And then these provisions went into effect in the tax year after the ACA was signed. So now we have this new charity data, so this gave us an opportunity to figure out, well, okay, well now that some of this information is now coming to light, let's see what hospitals are reporting to CMS, and let's see what hospitals are reporting to IRS, and ask the question, are they reporting the same numbers? Do they look the same? And so we got the data from CMS. It's publicly available. It's on their website. And then we purchased some data from GuideStar, which essentially compiles these Schedule H's from the IRS, and we do this comparison. Now, the definitions that the IRS and CMS give for charity care, they sound the same. I mean, we're trying to figure out how do there's nothing in, even though there's nothing in them that would make us think that the IRS numbers and the CMS numbers should be systematically different from each other. So in order to do this, and this is a messy business because there's no crosswalk between the IRS data and the CMS data that exists. So we had to create that. And then sometimes hospitals report to the IRS as a group. So if there's a local hospital system, they might report on their Schedule H as a group and then report to CMS as individual hospitals. And so we had to sort of figure that out. But we were able to match most of the not-for-profit hospitals. I think our match rate is well above 80%. The hospitals for which we couldn't really find a match for were typically small hospitals, below 50 beds. So just to remind you of what the objectives are, we're going to figure out whether hospitals are reporting the same thing to IRS and CMS, and then ask, is there any variation in the reporting of charity across the nonprofit hospitals? So first of all, what we find is that the IRS, hospitals report more money to the IRS than to CMS. So over the 2-year period, if we looked at all the hospitals, $20 billion to CMS, IRS, $18 billion to CMS. On average, the nonprofit hospital will report like $500,000 more in charity to the IRS than CMS. Now, when we did a paired t-test, so we just took the hospital, compared it to the amount itself to see whether there was a statistically significant difference. Yes, there is a statistically significant difference in categories. However, it doesn't seem that there's systematic underreporting or systematic overreporting by any particular hospital. So no hospital group, meaning teaching hospitals or rural hospitals or large hospitals, small, tend to overreport or underreport. We asked the question, well, are there any hospitals that actually report the same number? It happened 44 times in 2 years. So that's now there is a strong correlation between what's reported to the IRS and what's reported to the CMS. Let me show you the correlation first, and I'll come back and talk about that figure. So if you see this is a plot. On this axis is what the hospital reported to IRS, and on this axis is what the hospital reported to CMS. If it was, they tended to report the same, what you would see is you see a 45-degree line here, if it was sort of centered around. But as I said, hospitals report more to the IRS than to the CMS, so this line is a little below 45 degrees. And then you see the scatter plot. So doesn't seem to be that whether you're providing a lot or a little, that you're either underreporting or overreporting. And this is a scatter plot for, if that was in dollars, this is in percent of cost. And you can see the same thing, pretty much. Now, so then, what we decided to do is, okay, well, let's compute the difference and just plot the difference. So what we have along this axis is either the dollar amount, the difference between subtracting the from the IRS amount, the CMS amount, and then, or the percent, subtracting the percent, the IRS percent from the CMS percent. And what you see is that it's not centered around zero. It's a little slightly above zero, but then there are a lot of hospitals that are above and a lot of hospitals that are below. Which sort of suggests that, well, hospitals are not necessarily gaming their reporting. There's just a lot of noise in that difference. So then, what that caused us to think about is what that causes us to think about is, well, maybe what it isn't that hospitals are underreporting or overreporting. Maybe this is really about just making errors, or you know, it's not the direction of the reporting. And some hospitals are very good about reporting and report consistently, and other hospitals are not as good about reporting consistently, and they will make errors, and that error could either be for or against the hospital. So first we said, all right, well, just to ask, is there any factors that influence the difference in charity care? And there we don't see a relationship. The R squared is like 0.37. This is a regression which has about your usual suspects in these regressions: bed size, teaching status, payer mix, case mix, specialty index, a community index. There are area level market variables, control for competition, and then state dummies. And still we're only explaining with regard to the reporting differences, 4% of the variance. So this tells us that there really isn't any systematic gaming. So then what we ask is, okay, well, are there just errors? It's not systematic difference, just some hospitals are better reporting than others. And so we estimated a regression where the dependent variable now is the absolute value of the difference, and the independent variable are these hospital characteristics, market level characteristics, and state dummies. So this is what we find. Large hospitals, teaching hospitals, hospitals in healthcare systems, hospitals that provide safety net services, hospitals that are located in counties with minority residents and that have FQHC, those hospitals are the ones that seem to be making errors, in the sense that if defining an error, meaning their IRS number and their CMS number could be very different. And whereas hospitals that seem to serve Medicaid patients, that weren't the religious-based hospitals, specialty hospitals, contract hospitals, rural hospitals, if they were in markets where there was a public hospital or where there was a lot of uninsured patients, those hospitals tend to, their reporting tend to be much more consistent. Now, one possible explanation is that the hospitals in these groups are probably taking care of a lot of the uninsured and charity care patients. Those patients are coming to their door. And the hospitals in these groups, with the exception of the Medicaid patients, are probably not. And so, I trying to understand why this difference, maybe what's happening is that if you're treating these patients, they're coming in the door, and you have to do this distinction a lot, then you're not as careful. But if you're not treating these patients, then you're certainly a lot more careful when you're reporting about who's a charity patient and who's not. So the next thing that we did was we simulated the tax exemption. And here and what we did is we said, well, all right, well, we're going to look at the federal and state income tax, as well as the taxes that, the tax benefit of being able to issue bonds to tax-exempt bonds to bondholders. And to do this calculation, we're using I think a 33% marginal, 33% marginal tax rate for the hospitals, and then for the states, where essentially some states do have an income tax, some states don't. So depending upon which state the hospital's in, we apply an income tax. And then for the bondholders, what we're doing is here we're essentially applying a fairly modest yield on the bond, and then multiplying it by a 28% tax rate that presumably the bondholder doesn't pay because they're getting the yield from the bond. So the value of the tax exemption, we came up with $31 billion over a 2-year period, 18 of it being federal taxes, 2 being state income tax, and $9 billion, almost $10 billion in the value of the tax-exempt bonds. And when you compare that value to the value of the charity care that's being provided in the same year, or the same 2 years, then it's 50% greater than what's being, the value of what's being provided, reported to the IRS, and 65% greater than what's being reported to CMS. So this is essentially saying that for the industry or the hospitals as a whole, this is a pretty good deal if you just care about charity care. So everyone doesn't get a benefit, though. Benefits are not distributed equally. 75, because if you don't have a net income, you don't have profits, you don't get the tax exemption is zero. I mean, the value of it is zero to you in that year, at least the federal exemption. So 75% of hospitals benefit from the federal corporate income tax exemption. 61% benefit from a state income tax exemption. 54% benefit from a bond financing, because you got to be able to issue the bonds. So there are hospitals that really do well and hospitals that don't do as well. So we asked ourselves, what are the factors that predict a positive value for the tax exemption for not-for-profit hospitals? And some weird things came up. I mean, size. So being bigger means that you're more likely to benefit from this. But then these things with regard to whether or not you have uncomplicated Medicaid, maternity, newborns, uncomplicated births. Thinking about, so maybe the 2 big hospitals in Maryland that do births is GBMC, which is in Towson, and Holy Cross, which is in Silver Spring. Those are the places where lots of births are done. If you go to GBMC in Towson, that's where my daughters were born, it looks like a hotel suite. It's a very nice place to have a birth. Case mix index and this, if you're doing community service work. But these seems like it's not, we were looking for sort of those main things like teaching status, something like that would tell us something. Negative, if you were making things that had a negative effect on the value of your tax exemption, were things like if you were located in a county with a high poverty rate, or if they had a high uninsurance rate, or if the state, there were a lot of malpractice payments being paid out in the state, or if the hospital was contract managed. That had a negative impact on the value of your tax exemption. So we asked the question, well, does the value of the tax exemption have anything to do with the amount of charity care that you provide? And we estimated this model a number of different ways, and the answer is no. There didn't seem to be any correlation between how much the tax exemption was worth to the hospital and the kind of charity care, value of charity care that they were providing. So then finally, we decided to do an analysis where we said, well, okay, let's take the value, let's subtract for each hospital from the value of their tax exemption, how much charity care they're providing. Some hospitals, that number is negative, meaning they're providing more charity than the tax exemption. Some hospitals, that value is positive, meaning that they are receiving a lot of value from the tax exemption, but not giving very much charity. And we divided these hospitals in 4 groups, and we called one group, the groups in the tails, the net contributors, meaning that their charity is greater than their tax exemption, and net recipients, meaning that their tax exemption is a whole lot greater than their charity care. And then we asked, okay, well, what predicts who's in this group? And we use this third group here. So if you were a modest beneficiary of the tax exemption, what your ends up being our reference group, and we're predicting whether you're in this group or in that group. So I just said that. So what we found as with regard to net predictors of predictors of whether you're a net contributor is that if you're providing these complicated maternity cases, you're a trauma center, you're doing these community-oriented services, most likely you're a net contributor. If you're a high-cost hospital, or you're located in community counties with high percentages of black residents or an FQHC, most likely you're a net contributor. If you're small contract rural hospital, that's not, your odds of being a net contributor is lower. And then likewise, if you're in the state with these high malpractice payments. Now, I should just add the caveat, when we say less, we're less relative to that reference group, not less relevant to the net recipients. So this does not mean that these guys are more likely to be net recipients. This means that they're just not likely to be net contributors. With regard to the recipients, if you're large, specialty, again, if you've got these obstetric cases, these complicated obstetric cases, high cost, severe high case mix, you're more likely to be a net recipient. And then the small hospitals, medium hospitals are less likely to be in these less likely to be, this is a type of net recipient as opposed to contributor. I should say recipient. And hospitals that are in counties with high percentages of black residents, uninsured residents with these malpractice payments, less likely to be net recipients. So what does this mean? Well, first, some limitations. You know, if we wanted to pile on the hospitals, the tax benefit, we only just literally compute a portion of the tax benefit, because we don't include the properties taxes, the sales taxes, or the charitable gifts that they get too. And so the other thing is that the hospitals could argue, well, you know, we do those other things, and they are valued on the Schedule H, and maybe you should give us credit for that. And maybe I might be able to argue with Jerry and win that argument one day. But so what does this mean? It means that one, for sure, hospitals routinely report different numbers to IRS and CMS. At first, I think I really wanted to believe the IRS numbers over the CMS numbers. And so why believe IRS over CMS? Well, because it's the Internal Revenue Service. People don't lie to the Internal Revenue Service, do they? Really? Because the cost of them lying is really, but then I thought but there's no enforcement mechanism here. It's not like someone's going to read these reports and say, ooh, you provided $1,000 less or $100,000 less, let's go audit them. So these are not, it's not like, I don't think Schedule H is going to trigger an audit from the IRS. So maybe the CMS numbers are the right numbers because hospitals want to get the dish right and they want to get the EMR, the EHR right. The other thing is that not-for-profit hospitals probably don't provide charity care that's commensurate with the value of their tax exemption. And so despite this effort to try to clarify, I mean, we're closer, but we're not quite there yet. We still need to do some more if we want to know what hospitals are providing. Tax exemption is a blunt instrument. If you want to provide X, you might as well just tell the hospital what the X is you want them to provide and how much you want them to do. But the ACA, at least by providing some guidance, is a good start. So I want to stop here because I'm interested in hearing Maureen's comments. Thank you so much.
The name of the game right now, I think, around community benefit is about transparency and accountability. We here at George Washington University have a project that's focused on transparency and accountability, and it's really interesting to hear about another team of people who are thinking about and starting with transparency. Do the numbers at the hospitals, the tax-exempt hospitals, report to the IRS? Are they the same as what you report to CMS? And what does that mean? Why do we care? Why do we have standing? What makes that meaningful? So thank you for being here. Thank you for your work. And I really want to leave a lot of time for people to sort of ask you questions about that. What we've done in the Department of Health Policy and Management here at GW, Sarah Rosenbaum is my colleague. Here's the rest of the team sitting here. Sarah has been working on community benefit and a lot of related issues for many, many years. She and I together about 4 years ago said, you know what? As we're all thinking about what are the ways in which we are going to be organizing our healthcare system to align financing mechanisms with prevention and wellness, the outcomes that we're beginning to sort of move the system toward, as opposed to just paying for acute care in the hospital, there are going to be lots of things we're going to do, right? And we're funded in the School of Public Health to look at many of those. How do we think about private financing mechanisms? How do we think about incentives? How do we think about sticks? How do we think about the various ways in which we'll do it? How do we think about maybe the government providing some additional discretionary dollars and mandatory dollars for prevention and wellness? And Sarah says, shouldn't we also be thinking about how hospitals spend their community benefit dollars? So yeah, it's really important to understand how much they spend. We think, like you, it's really important to be able to look at the allocation of those dollars to what we now call financial assistance, highly distinguished from Medicaid differential, health professions training, and this category I just want to talk about real quickly called community health improvement and community building. Right. But we basically saying, gee, if the Affordable Care Act says, and those provisions that Darrell talked about, hospitals now must conduct a community health needs assessment. What are the health priorities in that community? You must consult with a public health person, people with public health expertise. There have to be people from the community who can work with the hospital and think about what are those needs and how would you prioritize them. The law is very clear about what has to happen about there. The law also says, okay, hospital A, you have to adopt an implementation strategy. What are you going to be doing, we would argue, in collaboration and partnership with all those people you brought together to think about what the needs are? What is it that you will do? How will you spend those dollars? We would argue outside the four walls of the hospital to get at some of the evidence-based strategies that we know that Hopkins is producing and GW is producing and lots of other wonderful people around the country are saying, if you invest the money in this way, you'll probably get better outcomes when it comes to the chronic disease issues that people are struggling with. But we look at the law and it says, okay, conduct a needs assessment. What are the needs? You look at the law and it says, okay, tell us what you're going to do. And then how would you know if a penny of that community benefit dollars went to what the need was and what might be a thoughtful, collaborative strategy? So what we have been doing with the support of the Robert Wood Johnson Foundation is creating a prototype to make transparent to anyone We're trying to design it user-friendly, and when we think of the primary user, we're thinking about the community-based organization in a neighborhood or a community who is beginning to understand, oh gee, the hospitals have this community benefit obligation and they spend their money in some way. Here's a resource where you can figure out how much is going to financial assistance, how much is going, and Sarah will tell you, to this ever-growing category of Medicaid differential, how much might be going to research. That sounds a lot inside the four walls of the hospital. How much is going outside the four walls of the hospital to invest in those strategies that we know will really get at the root causes of those very issues the community is going to identify, which is probably going to be substance use, much of it mental health, violence, a whole set of issues that are not going to be rocket science to figure out what those communities are struggling with. So we've created this prototype. It's going to be built into a website that anyone can go to, and it's the transparency of how the dollars are allocated inside the four walls of the hospitals versus outside the four walls of the hospital. And then the last thing I would say about that is that one of the things we're also interested in is what are the ways in which we can increasingly have the IRS understand what's happening in the field and where we want to drive it in some of these investments in community health improvement, but also that accountability piece. So for sure, this is an IRS compliance issue. I just couldn't agree with that point more. Hospitals do not want to lose their tax-exempt status. So I don't know if it's more accurate in terms of IRS or CMS, but I'm guessing they'll try to stand by those IRS numbers because they know that's where they can get in real trouble. But to some degree, what we're creating with our prototype is the ability, I don't want to overstate it, but the beginning ability of the community to hold the hospital accountable. To say, wait a second, we have standing here. The value of this tax exemption is you're not paying tax dollars in, but the expectation is that we're going to get something in return. And so we now understand that as more sort of community benefit, and this tool begins to give people not only information, but the capacity to maybe have good partnerships with the hospitals and use some of those dollars, but also to be part of the accountability process here, beginning to say, wait a second, how come so little in this category? How come so much in that? So let me just sort of stop there. I really just wanted to offer that as sort of an addition to how we're thinking about transparency and accountability here, but then leave the rest of the time for folks to ask Darrell some questions.
Thank you so much for your talk. What sort of policy levers do you think exist at the state and national levels to help bring the benefit more in line with the actual charity care provided by hospitals?
Well, I think, for instance, the state of Maryland, in its rate setting mechanism, requires hospitals to report their community benefit and produce a community benefit report. And those reports are publicly available. So in some sense, there's some transparency there. What's sort of missing in that report is you have sort of two sides of this. You have what we're doing, and then you have to value what the tax exemption is to them. And so we've just valued it as sort of foregone or taxes not paid in a sense. But you could, if you could imagine if the hospital could actually sell its tax exemption to someone, they could buy it. So it's because otherwise, if it's just foregone taxes not paid, the value always fluctuates from year to year. So what year in which we make money, then it's a big value to the year in which we don't make money, it's not. And so and that's one of the sort of the thing that sort of makes it fuzzy, because we don't know how big the obligation is, but then we also want to quantify these results, these things that the hospital does. And the other thing that comes by, sometimes what cities will do is cities will come and just ask for money in lieu of taxes. They'll just come and they'll just say, they'll negotiate with the institution and say, we need you to pay something to the city, and then and they'll ask for that something. But other than just sort of making them report, and then sometimes There's sometimes a state, like I believe this happened in Utah. They set a minimum threshold of what they expect that their not-for-profit hospitals do, something like 2%, because if you're not doing 2%, you're probably not operating. That's just the transaction cost, the cost of doing business. But there's still, you know, a lot of things in which we need to learn in order to really develop good policy in this area. I saw your hand over there.
So just to clarify the way they calculate, when you're looking at charity care costs or uncompensated care costs, is the calculation in relation to the amount of money they actually expend or lose, or is it in relation to what they could have gotten in the private, if it were a private insurer, or typical billing rates? Like, how is that?
So if you take the charges that are published, then you apply to those charges a cost to charge ratio to reduce them down to cost. So and that sort of gets you out of having to figure out what they would have charged a Blue Cross patient. If you just know their list price, you sum the list prices and say, on average, they get 30% of their list prices that are their costs are 30% of their list prices, then that's what it ends up being.
So it is really in relation to their spending and staff time and those sorts of things.
Yes. Mm-hmm.
So, one of the things maybe if you can just help me clarify is what I found somewhat heartening is that when you look at the health centers that PhDs, so by proxy, then they are in the areas of medical service, and that seems to have a very positive effect in terms of the amount of charity that those hospitals provide. So sort of thinking of them as tier 1 safety net hospitals. So what do you say for those that are sort of on the fringes in terms of defining them as sort of the safety net of charity hospitals, and sort of thinking policy-wise of sort of how you would sort of redish the funds that would be coming back to them?
Well, I don't quite understand your question. Could you just state it again?
So I think in terms of how at least in terms of looking at where the relationship should be in terms of the amount of charity and the exemption, you get the real value in the MUAs or the health center locations. Outside of that geographic area, how would you think about DISH formula for those hospitals that are outside sort of those critical service areas?
So this goes under that topic that your tax exemption is a blunt instrument. So in order to help the institutions that are actually doing the work, you got to spread a lot of money around. And so the question is, all right, well, Sibley Hospital is a Hopkins hospital now. It's located certainly not located in a medically underserved area. Should it have a tax? I mean, should it be exempt from paying taxes? Now, I guess if the CEO was here, I would obviously argue yes and say we do something that's charitable related. We do some community work, and yes, we should have a tax exemption. But if we were trying to provide food this way, we wouldn't necessarily say that a restaurant and a food kitchen, are doing the same work. They're both feeding people, but in one place, the people are paying good money to eat there. In another place, the people don't have any money to eat. But I think it's because of the way in which the policy has developed over time and the way in which hospitals have evolved over time, that we're sort of stuck with this policy. And the hospital lobby is a very powerful lobby. And if you try to take away this exemption or put teeth in it, you're gonna find that you don't have a lot of political friends.
And with our tool, you'd want to look at that and say, gee, seems like a lot of your folks have insurance, so interesting, how much financial assistance and why? Just guessing you're not seeing a ton of Medicaid patients. Why would that number be 30, 40% of what you're calculating is your community, I'm making it up.
Right, right, mm-hmm.
What that hospital would be. And like less than 2%, less than 1% in money outside the four walls to maybe invest in communities slightly outside their catchment area that in fact are in great need of an investment in a community health center or right. That's what so there's one question about whether or not they should have their tax exempt status, right? Interesting research.
Right.
Thing. So another question is, you've got it? Well, we now would like to sort of take a look at how you're allocating those dollars. And let's use an example of a hospital. We do frequently talk about hospitals that are in neighborhoods where you think the financial assistance and Medicaid number just shouldn't be that high.
Right.
Why is it that high? How do we make it accurate?
Right.
And if you still have the same obligation, why aren't we seeing more money outside the four walls invested in community-based organizations who probably have access and expertise in terms of thinking about those strategies? So it's
Right.
sort of a parallel thing.
Just one other thing. I once visited a health system one in Detroit and one in New York City. The local system had one hospital that was clearly the safety net hospital. And what they were doing with in the system was the hospitals in the system was really keeping the safety net hospital in its system afloat. So you could potentially see those kinds of transfers occur. So.
One, just comment, everybody should recognize that when you filed both the 990 and the 2552, it's implicit knowledge that the data is correct. It's an attestation. So the other thing is there's all sorts of other things going on at the local level, like what they just proposed in the jury, payments in lieu of taxes, even the state fund Medicaid. So they have to be considered community benefit.
Well, it depends. It'll either show up on the community benefit side of the ledger, or it shows up by reducing the value of your tax exemption side of the ledger. It's going to be on one of the two, if you're doing that calculus, if you're doing the comparison. Yeah.
So time is short, so I'm going to use my privilege as moderator to take the last question. So, you were excluding, and I think it's understandable why you did sort of Medicaid loss as one of the items of charity care. I think that's probably the item hospitals would dispute the most. Because in point of fact, typically from the data that I've seen, and Brian and I have done work on Medicaid dish issues, which are sort of its own complicated parallel to these questions, in which Medicaid loss tends to be far greater than the uncompensated care, charity care type stuff. But how you value Medicaid loss, you're right that obviously private hospitals do Medicaid loss, so lose money on that also. But the charity care, the safety net hospitals say, but we do more.
Right.
So we bear those losses at greater level. And maybe we have less charity care because we've done a good job of collecting for Medicaid. So it's messy.
Yeah.
How to distinguish what the sort of charitable role is and how you distinguish it from Medicaid versus the sort of charity care, uncompensated care type stuff.
Well, one of the way in which we've been thinking about this is because this isn't finished work in the sense that we just continue to look at these data and try to improve on what we've done, is we try to ask the question, if this hospital was a for-profit institution, what would it be paying? All right, so we're not going to give you credit for that. And now the residual is what we're going to give you credit for. And so in thinking about this issue with regard to the Medicaid loss, if we were going to include it, that's the way in which we would include it. The other thing that we just have to get around is, and this is the argument that Jerry always makes, is that the hospital, these are agreed upon rates. These are agreed upon rates. And so if they're agreed upon rates, they're negotiated and so forth like that, then they can we can't give them credit for it. And so I haven't won that argument yet. I don't. I mean, the difference between, I guess, there's the unreimbursed Medicaid payment, Medicaid costs, and then the Medicare shortfall. We don't like the shortfall at all, but the cost is I think there's some gray area there.